So by way of introduction, my name's Tim Robbins. I am a diabetes and endocrine clinician in the West Midlands region of the United Kingdom. We also work with Professor Arvanitis at the Institute of Digital Healthcare, and indeed I'm just completing a PhD with him. Alongside that, I'm one of the inaugural Topical Digital Health Fellows with Health Education England. And the presentation that Professor Arvanitis has asked me to give today is a presentation around digitally integrated diabetes care. I added the bit on the end around COVID-19, a catalyst for change. There's a lot of focus on restoring services around COVID-19, but I actually think that COVID-19 offers us the opportunity to have a catalyst to change what we do. And I appreciate Gunar's comment that I don't think COVID has changed everything, but it's changed some things. And I think it's certainly sped up innovation and integration, which we'll talk about. The things I want to cover today are starting off with integrated care in the context of the United Kingdom, and I call this a long-running battle. I debated whether or not to call it a battle because that sounds aggressive, but I think it's actually appropriate. I then want to talk about diabetes as an exemplar challenge for integrated care, and that's very relevant to C3-Cloud. So diabetes is one of the multimorbid conditions we talk about in C3-Cloud, and I'll talk a little bit about diabetes and multimorbidity later. Then I want to talk about emergent digital solutions to diabetes integrated care. And of course, C3-Cloud features within that. And then referring to what I spoke to at the beginning, COVID-19, are we restoring services or are we using COVID-19 as a catalyst to drive interventions around digitally integrated care, to move them into mainstream and to share best practice? So integrated care in the United Kingdom, a long-running battle. A lot of these slides are taken by a very good summary, which is a little bit out of date now, produced by the Nuffield Trust. But actually, integrated care as a general concept isn't new. It was first sort of discussed as an idea in the 1960s, and I think a lot of the elements around multidisciplinary care are really hard for what we call now integrated care at a very early level. And that multidisciplinary based care is very widely accepted in the United Kingdom and international healthcare settings globally as being how we want to deliver care, and the NHS adopted that in the 1960s. The 70s, 80s and 90s, I would say there was a lot of churn, a lot of changes and a lot of terminology that perhaps overlaps around partnership working, shared planning, disease management and interagency working. A lot of those terms have actually dropped out of the language we use in the NHS at the moment. But from 2000 onwards, we started to see some of the integrated care landscape that we see now, focusing particularly on patient-centered care, and C3-Cloud really promotes patient-centered care at its core, moving from patient-centered care to what I would probably describe as empowered patient care, alongside integrated care pathways and whole system working. In the UK context in 2019, we launched our 5-year forward view that set out how the NHS would work up until 2019. And from that emerged the concept of vanguards. For those that aren't in the United Kingdom, there are 50 vanguards in total that were developed in the end. And these were groups of organisations that were really given the freedom to start to define what integrated care looked like in their setting. And it was that freedom to experiment, to try and to create new collaborations that I think has been essential to where we are now, because those vanguards have transitioned to become integrated care systems in the new NHS context as promoted in our NHS long-term plan that was launched in 2019 and covers the next 10 years of NHS care. Central to that NHS long-term plan is integrated care, and central to that NHS long-term plan is digital care and digital enablement of care. It's also important to note that diabetes is one of the focus conditions within that NHS long-term plan. And I would argue that diabetes truly is an exemplar integrated care challenge. And what do I mean by that? I mean that diabetes is an example of where there is a challenge around integrated care. It's a high prevalence, high cost condition that spans organisations, and it's a big challenge. 60 million people in Europe are diagnosed with diabetes, and that is increasing. When I talk about diabetes, I do group both type 1 and type 2 diabetes together, but acknowledge that they are different conditions. 88.5% of those people with diabetes at a point in time will have at least 2 comorbid conditions. There's an interesting challenge and discussion between comorbidities, multimorbidities and complications. Certainly in diabetes, conditions like hypertension and renal failure I would argue should very much be seen as multimorbid conditions. Not only is it a large problem, it's an expensive problem. In the United Kingdom, it costs us £10 billion to manage our patients with diabetes. And 80% of that cost relates to complications or multimorbidities, however you want to phrase it. So if we can get it right for diabetes, then that's really important. But I tend to define integrated care by not defining it, because it's too diverse to define. I tend to define integrated care by saying it's the opposite of fragmented care. And diabetes as a condition actually is very vulnerable to fragmented care, because management of diabetes, if you're not careful, can be very event-based. The diagnosis is the first event, and then patients live with that condition for the rest of their lives, and events happen to them during that period of time. They have very little control over those events. They tend to occur quite suddenly and result in quite big changes for the patient and take the patient across organizational boundaries. And we need to move away from fragmented event-based care. And right at the start of the C3-Cloud journey, when we were writing the application to the European Commission, we spoke about the multimorbidity and the challenges of diabetes care. And we created this use case scenario, which I'm really pleased has actually preserved itself through to this stage where that's in C3-Cloud now, highlighting the fictional but very real for anyone who practices diabetes, 67-year-old lady who's had about 10 years of type 2 diabetes. She's quite passive about her diabetes. Her mother had it, and so she thinks she's going to get it too. But she's also quite scared about it because the previous generation suffered some horrendous complications from diabetes. Blindness was very common. Have much better treatments and much more effective screening now to avoid those complications. But people who remember family members with it, remember it with quite some anxiety and maybe pushing it from their mind. One of the challenges with diabetes is that it doesn't promote empowered patients, because when they treat their diabetes on a day-to-day basis, they treat their blood sugars, they don't actually feel any better. They change the numbers on the glucometer, but they don't feel better from it. And Mrs. B in this scenario actually went through and she went on to see her general practitioner because she was breathless. That general practitioner referred her to hospital because that was the right thing to do. But Mrs. B has limited mobility. And when she gets to hospital, she sees a consultant. It's the first time she's ever seen a consultant or spoken about her heart condition. The consultant will probably only have 20 minutes with her and often will be starting from just a scrap bit of information in a fragmented care system. He'll see her, he'll make a sensible plan and write back to the GP. Problem is that's going to take some time. And in that time, that patient may well get worse. She's on her own. There's probably very little monitoring the fragmented care system. And the only thing that the patient can do is rely on their immediate family and carers who haven't got a lot of conditions. So in this use case scenario, we actually propose that her husband phones the GP saying she's got a problem, but the GP quite commonly won't have that letter from the hospital consultant yet. She's therefore acutely unwell. She's developed heart failure. And at that point, there's no option but to admit that patient to hospital in quite a catastrophic event and requiring quite intensive treatment. And that's what we're trying to avoid from fragmented care. It's fragmented from the clinical perspective and from the way the patient views it. And that fragmented care results in passive patients who aren't empowered. That's not what we want from diabetes care. What we want is empowered patients. And actually what you can see on this screen is perhaps one of the most empowered patients you could argue for diabetes care. Theresa May herself, our former Prime Minister, does have type 1 diabetes. And you can see on her arm a Freestyle Libre digital monitor, which is a new approach to monitoring blood sugars digitally and helps to empower patients. Empowered patients can navigate this triangle of challenges that are going to occur throughout their lives, from a diagnosis of the patients through to potential psychological and dietary support. And to provide patients with the very best care, we need to link all these different steps together. But they are so diverse that the person best placed to manage and lead that care is the patient themselves. And we need to be able to put the patients at the center and at the heart of what we do to avoid that fragmented care. And digital allows us to do that. Digital allows us an opportunity to create empowered patients. That was what C3-Cloud, and it's been a privilege to see C3-Cloud develop and emerge over its 52-month program. It allows patients to be empowered. So in this scenario, in Brenda Jones's use case scenario, she initiated on a patient empowerment platform, C3-Cloud or something else, for example. and she's immediately learning about her diabetes. She understands why she doesn't feel better when she manages her blood sugars. And she creates a plan in collaboration with a general practitioner. The general practitioner has a clearer understanding of what medication she's on, and he can change and stop medications as is necessary and communicate directly with other specialties. That means a patient can avoid event-based care but have a flatter, more continuous care model that, as you can imagine, can avoid her being admitted to hospital. For the sake of time, I won't talk through this in detail, but by empowering the patient, by educating the patient, and by having a collaboration of the clinicians working together with a digitally enabled platform, we can have much better outcomes. We can avoid hospital admissions and avoid complications for these patients. The C3-Cloud is just one example. I think it is important to say that of the integrated care solutions we have. This is another thing that I've worked with Professor Arvanitis to put together, is supporting patients with diabetic foot disease. So this is one single complication which often involves management across multiple care settings, hospitals, surgery, GP surgeries, and surgical practice. And actually one of the challenges with foot disease is that historical models rely on textual descriptions of what is a visual disease. We weren't sharing photographs with each other as clinicians as to how foot disease was getting on. We just kept on writing it in the notes, which wasn't satisfactory at all. But with this device that we've implemented at Coventry Hospital, patients themselves are empowered. They take weekly photographs of their ulcers, and their care team can see them, and they can see them getting better. And it's not just the highly complex patients we need to worry about. Gestational diabetes is at the relatively low concern end of the spectrum in terms of severity of diabetes. It's normally quite mild and managed with diabetes or tablets in the majority. But historically, patients were scribbling in little notebooks what their blood sugars were, and we would rely on them bringing those notebooks to clinic. And instead, what we've implemented is developed out of Oxford. This app is something that allows people to automatically upload their blood sugars and to share them with their clinical team. And for COVID, that's meant that these vulnerable pregnant ladies haven't had to come into hospital to show us their little book. Because I would argue that COVID has been truly transformational in terms of how we deliver care. And there's been a huge amount of innovation. This quote, I think, from the Health Services Journal is that we have seen more transformation of health and care services in the last 4 weeks than we have seen in over 4 decades of integrated care policy initiatives. There's been changes where we've removed some of the barriers, be they legislative, policy, or organisational, and we've come together, both inpatient services, specialist services, and communities that have needed to work together to get through COVID. And I think it's really important that we identify those opportunities that have arisen, those innovations, we share them, and we disseminate them. I think that quote is ambitious, but I think it highlights the changes that have happened during COVID. And again, at Coventry, we've demonstrated that. This is a Freestyle Libre system that I mentioned in Theresa May. Before COVID, this was purely used on an outpatient community basis. But actually, why should it be? Why don't we start it in hospital to support management of patients in hospital, which actually limits people having to go into rooms to do blood sugar meters, so readings, so it protects nurses, but it allows us to get a better understanding of a patient's blood sugar, prepare them in hospital with a system they can use out of hospital, and manage that transition from inpatient care to community care far better. And I thank the Winston Churchill Memorial Trust for funding some of that work at pace during the COVID challenge. But I've spoken about sustaining the innovation that we see in integrated care during COVID-19. And I think the real challenge with that is workforce. So I'm honoured to be one of the Toppel Digital Health Fellows, which has emerged from Eric Toppel's review of the digital health landscape in the NHS. And we know that clinical education typically lags behind real-world practice. But if we want to deliver digitally enabled, integrated care systems, we need a workforce that can work in it. And we need our universities, our clinicians, and our future students to work together to unlock the potential in workforces nationally and internationally to be able to deliver high-quality, digital integrated care to our patients. I would argue the NHS is a fantastic place to do that, with the ability to leverage what is a global reputation and our integrated data sets to attract people, educate and train the next generation. But it shouldn't just be one country. It should be something we need to achieve nationally and internationally, focusing on our workforce and the next generation. So thank you very much for listening. I hope I've just about stuck to time. And if you've got any questions, please do let me know. And I think there'll be a session at the end.
Thank you, Tim, for this very informative talk and your contributions.